Hello and welcome to Lynchburg Live. I'm your host, Linda Smith. October is Breast Cancer Awareness Month. For the past 3 years, we here at Lynchburg Live have attempted to bring educational information to our audience about the disease, including available options following the breast cancer diagnosis. My guest tonight is reconstructive surgeon Dr. Sylvester, who practices with Plastic Surgery Associates of Lynchburg Incorporated. He will be discussing options for women following mastectomy for breast cancer. This is the first of a two-part series featuring Dr. Sylvester in exploring this topic. Dr. Sylvester, welcome to Lynchburg Live. You know, one of the things I think I said to you as we were planning to do this show is that even with all the information available today for women, there's still so much fear associated with breast cancer, with the diagnosis, and then with not knowing if you're going to have surgery that's going to leave you not feeling like yourself. And you know, just to start out, I wanted to say that that's a terrible thing to have to face at, you know, those two things at a time.
Exactly, and I think a lot of women don't want to even think about it if they don't have to.
Right.
So it's not, reconstruction is not something that most women, I think, investigate if they don't have to investigate it.
Right. All right, so following the breast cancer diagnosis, why do some women need a mastectomy while other women can get away with just having a lumpectomy and follow-up chemo or radiation?
Sure. I just wanted to point out that reconstructive surgeons, the plastic surgeons who are doing breast reconstruction, are not breast cancer surgeons.
Right.
So the information about that I'll give you is the information I know. I don't make decisions for patients about the best type of breast cancer surgery to have. And as I tell patients who I see, particularly for seeing them before their breast cancer treatment, the most important thing is eradication of the breast cancer, and then the consideration of the type of reconstruction and how to do it comes in. Did you specifically ask which is the best, the decision about which is best?
Yeah, I just
Sure.
wondered why some people have to have one thing. I mean, I know, but I thought
Sure.
maybe you'd like to share with our audience why.
I might have you tell this. My understanding, again, of this is depending upon the type of cancer,
Right.
the location of the cancer, the size of the cancer, et cetera. And in conjunction with the patient surgeon, the oncologist, the doctor who treats patients after surgery, the radiation oncologist, the radiation doctor, a decision will be made or a recommendation will be made to the patient as to which they feel is the best approach to eradicate the tumor and at the same time to try and preserve as much tissue, the patient's natural tissue, as possible. So in Lynchburg, we're very fortunate. We have a breast cancer large committee that's multidisciplinary, meaning all the physicians that I mentioned that meets every week, and virtually every case of breast cancer that comes through Centra Health is discussed at this meeting, and there's a consensus opinion that is usually given to the patient that says many physicians from many different disciplines have participated in this, and this is our recommendation, or here are some of the options that you can choose from. Based upon your own desire, you know,
What to do?
With the understanding that we're still going to try and recommend to you what is going to be the best procedure, one, to first eradicate the cancer, and then, if you choose to have reconstruction, how to approach that.
I think it's so wonderful that there are a group of doctors who look at each individual patient from all sides of what they're going to be going through and how they're going to progress, and what will probably give them the best overall result.
It's a great idea to have that, and the fact that all these doctors meet at the same time, so everyone kind of knows what the other person is thinking and going to do, I think produces the best result for the patient, to have this multidisciplinary approach to making the decision about the best treatment, both to eradicate the cancer and then if a patient chooses to have breast reconstruction. I agree.
So at what point is the reconstructive surgeon really called into a case?
Right. And this will vary, and it depends upon several things. It depends upon the general surgeon and the oncologist or radiation therapist when they think it is appropriate. It also depends upon patient wishes. Sometimes patients who are not going to do what we refer to as immediate reconstruction still would like to talk to the reconstructive surgeon just to be reassured that I can have reconstruction at a later date if I choose to do that. So we'll see some patients prior to their surgery, even if they're going to have what we refer to as a delayed procedure that might begin 6 months or a year later. So, as I said, it depends upon several things. One, if it is reasonable to do immediate reconstruction, then oftentimes the general surgeon will send the patient to see us and then coordinate surgery with them. There are other times, for any number of reasons, that it is best to do a delayed procedure, and in those cases sometimes we'll speak to the patient before their surgery just to kind of reassure them, to tell them this is possible if you choose to do it, and I think it makes them feel better if they're the type of person who would want to pursue breast reconstruction.
Yeah, I think it's really important because those first, that first month when you're going through so many things and you're really overwhelmed, and it's so good to know that you've got a number of people who are looking at your case and making suggestions as to what will be the best for you.
Exactly, and of course, as we find as these breast cancers are being detected earlier and earlier, the survivals are increasing dramatically.
Right.
And when the patient is first hit by this information, it's bad information, and they want some good information. Right. So in that sense, reconstruction for a lot of women is good information, and I think it helps them through that process to just know that it's available if they choose to do it.
And I'd just like to say here that with early detection, breast cancer is not a death sentence like it used to be. Exactly. And it's really important, I think, for people to maintain their body image. And, so what is breast reconstruction?
Well, breast reconstruction is exactly what you just said. It's reconstructing the breast. One thing that I tell patients who are going to have reconstruction, that the reconstructed breast is not the same as the unoperated breast. Because we cannot reconstruct at this time what we refer to as a functional breast. And if by function we mean that it has an ability to lactate, a breast that has been removed or a mastectomized breast, you cannot create ducts in the breast. Also, more times than not, patients will have at least some, if not very significant, loss of sensation to the breast. So the goal in reconstruction is body symmetry, to create two breast mounds of approximately equal size and shape, so that a patient in her clothing, in her swimwear, can feel comfortable and feel symmetrical. One thing we hear from patients who have had mastectomies is, I just feel lopsided. And I think a large number of women do fine just using a prosthesis. There are other women who would feel better with a reconstruction where
Right.
they did not have to wear a prosthesis.
Right. So your goal is just to make people look and feel as much like themselves as they can.
Correct.
Yep.
In reconstruction, like I said, two breast mounds of approximately equal size and shape.
And breast reconstruction, I think I sort of slipped past that, is done pretty exclusively for mastectomy patients.
Correct. I'm trying to think. There are a few congenital situations. One is referred Poland syndrome, is a condition where you don't have breast development or muscle, the pectoral muscle on one side. And I've been in practice 34 years. I think I've seen 2 young women who had Poland syndrome, and we did reconstruction for them. But the great majority are women who have had breast cancer surgery.
Now, are there risks associated with reconstruction, or just what you would assume?
Right, and the risks are very similar, if not the same, as those associated with most any surgical procedure. Patients who have what we refer to as comorbid conditions, meaning patients who are diabetic, have heart disease, lung disease, etc., are at greater risk. A patient who is otherwise healthy, and because this can be what we call an elective stage procedure most of the time, you would do the procedure when the patient was as healthy as they can be.
Right.
Where a patient who has an appendicitis and they have other problems, you can't wait till they get over their cold before you can operate on for reconstruction. It's done in most cases as an elective procedure, but there are risks of infection, there are risks of anesthesia, blood clots in the legs, etc., are concerns that we address at the time of surgery and attempt to prevent them as much as possible.
How soon following a mastectomy can reconstruction begin?
Again, there's a whole spectrum. There are some patients who are candidates for immediate reconstruction. And by immediate, I mean the reconstructive process is begun immediately after the mastectomy at the same general anesthetic or in the same hospitalization. So I think later we're going to talk about the many different types of reconstruction, right. But several different types of reconstruction in some patients can be done immediately, or at least the process can be started, because some of these procedures will take, some of these reconstructions will take more than one procedure.
I asked you earlier, if someone has had previous radiation or chemotherapy, does that have an effect on the kind of reconstruction that you're likely to be able to do?
It does, and I'll separate the two, radiation
okay.
and chemo. Radiation, the area that is radiated is the breast that has cancer, and radiation, of course, does a lot of good things to destroy cancer cells, but in the process it creates changes in the skin and the muscle, and there are skin changes and what we call small vessel changes and firmness or fibrosis of the muscle. That makes it more difficult to do reconstruction, particularly certain types of reconstruction. One where you would want to stretch skin or muscles, much more difficult in most cases where patients have been radiated. So in radiated patients, we oftentimes will choose a procedure different from the skin stretching, or what we call expander reconstruction. The chemotherapy has to be considered in a patient who desires reconstruction. We usually will coordinate this with the oncologist, because we know that chemotherapy, certain types in particular, may reduce a patient's resistance to infection. So we always coordinate that with the patient's oncologist to say, when is the best time for us to do this? And oftentimes it'll be a month or 2 months or 3 months after they've finished a certain course of therapy. But it's important to coordinate that with their oncologist.
How about the stage of breast cancer? How does that influence reconstruction or the possibility of it?
Yeah, and quite honestly, that is not an issue I address. I basically ask the oncologist, right. The radiation therapist, routinely I'll say, do you have any recommendations or reservations about reconstruction in this patient? If the oncologist would be concerned that a type of reconstruction we were doing in a patient who had a high chance of recurrence, they might ask us to delay that for a period of time.
That's probably a smart thing to do. Now, how about the size of the natural breast? Does that factor into the decision to do reconstruction?
Well, in this sense, if the goal is to create two breasts of approximately equal size and shape. So in a woman who has a small breast, it is easier, of course, to create a breast
right.
mound to match a small breast than a very large pendulous breast. And oftentimes in women who might have a very large pendulous breast, it's better to reduce the large breast and create a breast that of what I would call medium size, because it's very difficult to match a breast that would be very large or may have some drooping or what we refer
for
to
balance.
as toe. Correct.
Okay. All right, there's several types of reconstruction, and you're going to tell me about all of those, aren't you?
Well, I'll tell you about as many as I know about.
Right.
I've been in practice a long time, 34 years now, and my younger partners do most of the breast reconstruction in Lynchburg. Now I do some, mainly from patients who've been mine for years that still choose to have me do their surgery. There have been some newer procedures that my younger partners do that I don't do, and so we'll discuss any number of these different procedures.
Okay. All right, you've brought some pictures. Talking about the flap procedures. So Phil, if you'll put those pictures up on the screen, Dr. Sylvester will tell us what they are.
We're going to discuss apparently these, what are called flap procedures,
right.
And we'll talk about when we would use these rather than other types of,
okay.
Of reconstruction. This procedure uses a muscle that's on the back called the latissimus dorsi muscle. This muscle is very similar in its size, shape, and thickness to the muscle that ordinarily sits on the anterior chest wall beneath the breast, and that's called the pectoralis muscle. If a patient has received radiation therapy, if the patient has had all or part of that muscle removed, which is not very common today, used to be more common years ago with a radical mastectomy, we would use this flap, and the dotted area we refer to as a skin paddle. And by paddle we mean we're going to transfer skin from the back that would basically be about the same size as the skin that was removed at the time of mastectomy. And in addition to that, this muscle is also transferred from the back around to the front of the chest. And with this type of reconstruction, we would always, or virtually always, use a mammary prosthesis or an implant, because this muscle and this skin paddle is not large enough, in most cases, to create a breast mound to match the opposite side. I think we might have another picture that would show, and this shows after you have removed the muscle and the skin paddle, you can generally close this as a straight line, so the patient has what we refer to as a donor scar on the back, and we try to put that in a place where it would be covered by most types of garments. And then this just shows the muscle and the skin paddle, what we call inset, and that ellipse of skin generally would be very similar to the skin that is excised and, of course, the underlying breast tissue at the time of the mastectomy. And then beneath the skin and muscle, we place a prosthesis.
So the skin is transferred with the muscle?
Correct.
So
the blood supply comes through the muscle and then up into the skin. And we refer to this as a pedicled flap. The blood supply comes mainly from the portion of the flap that is under the arm. All of these have been mapped out where the blood supply comes from, and you just respect where that comes from and protect it during the surgery, because that's what keeps the muscle and the skin flap viable or alive.
yeah,
This shows the results of another type of reconstruction, and some people refer to this as the tummy tuck reconstruction. It's basically where you can reconstruct a breast using all of the patient's own tissue, so you do not have to use a breast implant beneath it in most cases. Some people have a preference for this, who say, I really don't want to have an implant. Another advantage of this is that the tissue is all the patient's own tissue. A good percentage of it is fatty tissue, which is a good part of breast tissue. So if later in life a patient would gain or lose weight, you would expect this breast to increase and decrease, similar to the opposite breast. Where reconstruction with breast implants, of course, the implanted side is not going to change if a patient gains or loses weight, and we sometimes at a later date have to go back and replace it with a larger or smaller implant. The other thing that happens is that with this procedure, patients basically get a tummy tuck, because the tissue that usually is discarded, tissue from just above or just below the umbilicus down to the suprapubic area, is generally discarded in a tummy tuck. This is the tissue that is used to reconstruct the breasts. The blue arrow here shows that actually we use that. There's a muscle that runs up and down called the rectus abdominis muscle, and there's a nice strong blood vessel in there that again keeps the muscle and that skin paddle, as we call it, alive or viable.
And this is transferred to the area by tunneling under the skin?
That's a good question. Yes, it is. And I told you there are some newer techniques. The newer techniques, this is called a pedicled flap. We used to call, I'm sorry, forget that. This is called a pedicled flap.
Okay.
They are now doing what are called free flaps, where that muscle and that the skin paddle is detached from where it is, and then the artery and vein that supply the blood to it and from it are then sewn into other vessels in that area, particularly branches of the internal mammary vessel. And it's called free because it's detached and repositioned. But plastic surgeons say it's neither free nor is it a flap, because once it's detached, it's not a flap, and it's not done for free. So, but it is a type of reconstruction, and it's referred to as free flap reconstruction. And it actually has a more robust blood supply than traveling that long distance through the muscle. And some patients, depending on their body shape, their body habitus, their height, are better candidates for this type of surgery, what we call the free flap technique, than the pedicled flap that goes through the muscle.
Do you have the same recovery response to the free flap that you do with the pedicle? I mean, pretty
I
good
would think
response.
that recovery time, whether you do it as a free flap or as a pedicled flap, would be very similar, because basically they're all the same incisions that are being made, yes.
So are all mastectomy patients candidates for these flap procedures?
That's a good question. And the answer is probably not, but not because you can't design a procedure for them, that there's not a procedure that would work. It would depend upon the other factors, meaning their health, their desire, comorbid conditions, et cetera. It's rare that we'll see a patient that one of these techniques will not work for reconstruction. It's very rare that one of these techniques would not work.
You know, with these flap procedures, to me it looks like you're really doing two procedures.
Well, I mean, you're exactly right. One procedure is harvesting, you're harvesting the flap.
Right.
And generally they're done as a team of two doctors, because you harvest the flap together. The one doctor then transfers the flap and does what we call the inset, sutures it in, puts it in place, while the other physician is closing the donor area, whether it's the tummy or the back. So it really is two procedures.
So does that
combined.
require extra time and recovery because of it, or is there anything specific to having had this done that makes the recovery different?
Right. Well, the recovery from these flaps is definitely generally longer than when we do reconstruction with what's referred to as tissue expansion, which we really haven't covered yet. Oftentimes the tissue expansion procedures, if it's being done at a delayed, can be done as an outpatient, where patients who have particularly the tram flap, probably the longest recovery is tram flap, might spend 3 or 4 days in the hospital afterwards. A day or two will be spent in intensive care, because we monitor the flaps very carefully to make sure that the blood supply is adequate. If a patient starts to have a problem with that, there are things that can be done to what we call salvage or recover that flap. So we want them for the first 24 to 48 hours to be monitored very closely.
Okay, I have another question that's kind of off of this a little bit, but I have a friend who had a breast reduction, bilateral breast reduction. Mm-hmm. In the process, they found a very, very small cancer. Do you see that happen, or do you know of that happening frequently, or?
I know of it happening, not frequently. As I said, I've done breast reductions for 33, 34 years. I've never had a patient, and we routinely send the breast tissue.
Right.
I've heard of, I have friends who are plastic surgeons who have had patients that breast cancer was found. I think on one occasion when I was managing a reconstructive procedure, we found a recurrence that hadn't been detected otherwise. A procedure that is done, if a woman who has a large breast is a candidate for breast reduction, and a tumor is found in the lower portion of the breast, which is the portion that is generally removed with a breast reduction, you can, if the general surgeon and the oncologist, et cetera, think that they can eradicate the tumor by removing that portion of the breast, we have at times participated with the general surgeons in basically doing a breast reduction surgery at the same time, where they remove the tumor, and it still allows us to preserve, say, the nipple and areola complex, and to reduce the size of the breast, but to produce a normal shape to a breast.
So follow-up with mammograms more frequently for a certain period of time probably would be the thing that patient should have done.
Again, the oncologist is the person who follows most of these patients, and they do, again, depending upon the type, location, tissue type, their receptors, make recommendations on the frequency with which they should have mammograms or other types of screening tests.
That's, I think it's so important for women to know going into something like this, which is very frightening, that there are options out there to continue life, without much of a hiccup, just to keep going on and to be themselves and feel like themselves, because it's very, very difficult going through chemo, losing your hair, then maybe having to have a mastectomy, and all those things hitting you at once is a difficult thing.
Sure. I've had more than one woman say to me, after this, I just held my breath for a year, 2 years, or whatever, and then I decided I'm going to get on with my life, you know. But I think that period of time varies for different people, and but I think it's a common thing that, you know, it's a real shocker. It is.
It is. I thank you so much for being on this show, and we're looking forward to having you back next week.
All right.
To continue talking about breast reconstruction, and I think you have some things you're going to show us.
I do.
On the next show. I hope you've enjoyed tonight's show, and we'll tune in next week for part 2 of this series featuring Dr. Sylvester and breast reconstruction. Thank you so much for watching. Have a wonderful evening. Good night.